Thank you. Welcome to Panel 2, and thank you to all of those of you who traveled very far, or traveled not so far, but it was a difficult travel to get here. You'll see in this panel that we have quite a few people on the line, on the phone, and we'll work to make communication as good as we can, but I ask you to be patient considering what they've been through in their geographies. So let me ask the speakers who are present to come forward. And for those who I believe are on the phone, I'll ask you if you're on the phone, and if you could acknowledge, I'd appreciate that. I'm Victoria Hale, a member of IOM and a member of this committee, and the founder and CEO of Medicines 360, a nonprofit pharmaceutical company based in San Francisco. We're pleased to be here today. We have a group of 9. Rainier Engelhardt is Assistant Deputy Minister of Infectious Disease Prevention and Control Branch, Public Health Agency of Canada. He is in seat number 2. Osman Mansoor, Senior Health Advisor, New Vaccines, United Nations Children's Fund. Is that you on the phone? Yes? Okay.
Yes, I am.
Great, thank you. And then Joachim Hombach, Senior Advisor, Department of Immunization, Vaccines and Biologicals for WHO. Yes, raise your hand, thank you. Ademola Olajide, Head, Health, Nutrition and Population, Department of Social Affairs, African Union Commission via phone. Are you with us, Ademola? Okay, maybe later. Alex Palacios, Special Representative, GAVI Alliance. Thank you. Genevieve Meier, Health Economics Manager, North American Vaccines Division, GSK Vaccines. No? On the phone?
Yes, I'm on the phone.
Great, thank you, Genevieve. Diana Latoni, Executive Director, Vaccine Ventures and New Products for Merck. Are you on the phone? Also on the phone, great, thank you. Seth Hetherington, Chief Medical Officer, Genosea Biosciences, member of the National Vaccine Advisory Committee. Seth, thank you. And then Ann Ginsberg, Vice President, Scientific Affairs, ARIS. Excellent, we're all here. Okay, great. So we ask everyone to turn their cell phones off if you haven't already, and we invite questions via email or online, and we will take them toward the end of the session if there's time. So let's begin then with Rainier Engelhardt. I ask you to present. Thanks.
So thank you very much. First of all, let me say that it's truly a pleasure to be here and assist the IOM in this project. It's one that's drawing a lot of attention in Canada as well, and maybe my remarks will sort of point out to you why. Maybe before commenting on the SMART approach very specifically, as you've asked for, I'd like to maybe give you a little bit of sense of why it's even of interest in Canada and some context for that. I mean, I think we know that Canada is pretty closely allied to the US no matter what. But in the case of immunization and vaccines and the responses to infectious disease events, we have some very specific arrangements, right? We share databases, immunization databases included. We have legal agreements, such as under the North American Plan for Avian and Pandemic Influenza, such as our relationships that are there for medical countermeasures, which includes vaccines, and the cross-borders initiatives, et cetera. There are a whole series of formalized initiatives that frequently have immunization and vaccines as some sort of sub-theme within that. A little bit of additional context as well. Canada is a federated state. Being a federated state, yes, we have a national government, we provide national guidance. I like to think of it as national leadership, although there are others who would disagree with that, especially in the provinces and territories sometimes. I'm sure it's about the same here with state and federal governments. But it's a formalized structure, so that whatever we do in Canada with respect to infectious disease, immunization included, really has to be ideally on a consultative basis, on a coordinated basis, on a basis where consensus is derived to make particular decisions about vaccines, about use of vaccines, vaccine programs. And as that, the overarching element to that is that from a public health perspective, we talk about, like we all do, about having equal access, equitable treatment of all populations in Canada, in this case in Canada, whether even including special populations. So that's a backdrop. The instruments that are there to allow us to do that, and we have, in fact, we have our American cousins participating in some of these instruments, are such as the National Advisory Committee on Immunization and the Committee to Advise on Tropical Medicine and Travel. These two have representation from federal governments, provincial governments, territorial governments, and they produce guidelines, case definitions, etc. Then there's also a Canadian Immunization Committee, which again is a federal, provincial, territorial committee that considers cost aspects, inputs from stakeholders, physicians, programmatic applications. Ultimately, vaccine program policy is made by the provinces and territories, with each of them conducting their own reviews and establishing their own schedules. Sounds like a mess, right? But in reality, what we try to do is bring people together, and it's working reasonably effectively in that whole decision-making process. And this is really one reason why the Smart Vaccine Project is quite of interest to us. So in practical terms, most of the publicly funded vaccine programs in Canada are purchased through a bulk procurement program, again involving the provinces and territories, the jurisdictions, the multiple jurisdictions and all that. The current approach that we use is an evidence-based approach to make those decisions, but we only tend to look at vaccines one at a time. For instance, should we recommend a pertussis vaccine in pregnancy? Should we recommend a meningitis B vaccine? That sort of thing. There are a lot of open questions, and we do have in Canada a national immunization strategy that was developed in 2004, has been guiding us since. That is now currently undergoing intense review to really reassess all those policies that are in place about immunization in the country. You know, that relates to vaccine selection, priorities for purchase, for development, R&D activities included, et cetera, stockpiling potentially. So we're building stronger networks internally for vaccine evaluation and really developing some innovative approaches for existing products. The SMART approach here has a potential for us as well in Canada to change the way vaccine evaluation decisions are made. So it's not just your country. I mean, the SMART program could be a significant model outside of the US. And my own staff is closely evaluating SMART vaccines right now as an approach that we potentially could adopt as it sits, or frankly, it has so much flexibility inherent in it, it can be very easily adapted to a Canadian approach as well. I mean, its strength is really in identifying all, as we said, all those different attributes that may at times be in conflict that drive decision-making in vaccine use and immunization programs, and encouraging really the participants to develop, to share almost their opinions and the evidence basis to the weighting of those attributes. With respect to some of the challenges that we already raised this morning, so I don't want to dwell on too much, with such approaches, is a question of validity. I mean, it's really going to work only as well as the data is there to support those individual decisions. So the data sources themselves, and I noticed that data sources have been brought in extensively into the SMART program to be encouraged even more, and I said already that additional Canadian databases which are there could be made available to you. That I think over time and use will allow the whole SMART approach to work better. There's always going to be some bias, of course, in how these various weighting factors are adapted, and maybe that's part of the benefit of using that SMART approach, in that the biases become obvious. I think we talked about that this morning. It's very transparent, It allows the parties that are making decisions on immunization, on vaccine use, and often they're coming at it from very different perspectives, to at least lay in a structured fashion their opinions and their views on the table. I think that as the smart vaccine approach gets practiced more and more, these weighting factors and how to deal with them, that'll become much more generally accepted as an approach. But, you know, one need that I think we briefly mentioned this morning that might need to be assessed is really the question of public acceptability, relating that transparency outside of the practitioners that are trying to come to decisions, but really finding some way of demonstrating that these immunization decisions that are made have gone through a deliberated, detailed, and complex process. And there's a public communications aspect to this that could be very beneficial, because the success of any decision coming out of using the structure is going to be measured by uptake, vaccine uptake. You know, issues such as, additionally, perhaps issues such as more shots versus multivalent approaches versus injection versus non-invasive approaches, what are the benefits pertaining to that? I think that's all part that could be considered here in this model. Broader strategies that relates, as I said, to multiple vaccines in certain targets, such as in maternal immunization, might also be a worthwhile consideration in the model. At the moment, I can't really, and I'm not really equipped to comment very specifically on the software element, the algorithms that drive the software model. But I have looked at the output of that. I mean, it's pretty complex at the moment. I think it becomes very important, the intent that's already there, is to make the smart vaccines model be very user-friendly. Because ultimately, if I look at the Canadian experience, the people who are going to be wanting to use that model have no facility with complex modeling. They need to be able to approach this and use the tool individually in a fashion that they can easily handle. So that user-friendliness, I think, is critically important. We briefly talked about additional trialing. I think that's also an important point to create confidence. Trialing with some additional examples, actually hindcasting in a way, taking some examples of scenarios, vaccination scenarios, for which we already have good confidence that we made the right decision, run it through that model with all of its complexity, and frankly see whether or not we end up with the right decision. Sorry, the same decision on that. So, just to reiterate, from Canada's perspective, we're definitely interested in working with you in further developing the smart vaccines model. I could even offer that we'd be willing to do a pilot study on it, trial it that way, in a different setting. We're evaluating it right now. The response from my folks has been, as I said, very positive. And it's all in the context of it being a decision support tool, not making a decision in itself, but allowing an open and transparent interchange to achieve some sort of single decision out of typically from a large group of people. It's also an R&D planning tool. We haven't spent that much time about this as yet, but if you were to run this model from a sensitivity analysis perspective, identifying sort of some critical elements which prevent a vaccine B or vaccine C from being a high priority because it has some inherent flaws, where would you be putting your efforts in order to fix that problem and make that vaccine, which otherwise would be very important in its application? So it can be run upstream and I think also downstream. So with all that, I very much would say that we support what you're doing here, offering to participate in it in the future going forward. And with that, thank you very much. Anybody has any questions, I'm happy to answer them.
We'll have you sit and take questions later. Thank you, Rainier. Now our next speaker will be via phone, Osman Mansoor, United Nations Children's Fund.
Hello, good afternoon, everybody. Can you hear me clearly? Hello, good afternoon. Are you able to
Yes,
hear me?
we can hear you.
Okay, good. Thank you very much. I'm sorry, I was listening to some of these other calls, and some of the phone calls are very hard to hear, so I hope you're able to hear me clearly, and if not, please stop me. Firstly, thank you very much for asking the inputs of UNICEF into this. UNICEF as an organization is really committed to reaching more children with more vaccines, and our focus is really on low income and middle income countries.
Excuse me?
As an organization,
Osman?
we're not really focused with
Osman?
getting new vaccines into the market.
Excuse me? Excuse
Yeah.
me, please? We're having a little bit of difficulty here understanding you. Could you speak a little more slowly? Please?
Sure. Thank you very much.
Thank you.
UNICEF's focus is on reaching children in low and middle income countries with vaccines that are available and are life-saving. The use of this model, therefore, for us is less about the investments in the future, but about the potential for such a tool for prioritization of national program managers in existing, to adding to existing programs. And I think the point's being made by several speakers, which I would again endorse, that this is useful as a tool to help in the thought process and the decision-making process. And I think the danger is that it's seen as a tool that will make decisions for people and tell the direction that it has to go. I think as I see this tool developing and potentially becoming such a tool that national program managers can use to help them decide not only which vaccine, but also the different options of the same vaccines are available, I can see it has some value. As was mentioned before, I think the opportunity to identify some of the key parameters which are holding back consideration of a vaccine or not, I think can be better understood through playing a tool like this. One of the key challenges that was mentioned was the issue of the lack of data, and of course that's particularly acute in resource-constrained settings. And I think in some ways a model can actually help address these lack of data by providing a range of likely assumptions and seeing what impact it has on those decisions. I think I will leave my comments at that for the moment. Thank you.
That's great. Thank you. That's a very brief presentation, very succinct. Did I say at the beginning of this panel that this represents the international and private presentations? I need to do that, if you hadn't intuited that already. Okay. Thank you. Okay. On to Joachim Hombach, okay, from WHO.
Thanks very much, and I'm very pleased to be here and to have an opportunity to comment on this really very, very ambitious exercise, and which is hugely interesting. And let me first say, I think very important and topical, because I think vaccine decision-making or vaccine prioritization is probably becoming even more important on the one hand side because we have more choices, in particular in relation to vaccine introduction, but then we also have higher costs. So I think, and in a context of resources constraint, you have to think about prioritization, and so this tool, if it helps, would certainly be very, very welcome. With this, I also want to make the point that others have already made. I think this tool, and I believe that's the way it is being designed, is not just for pipeline vaccines, but also for existing vaccines. And I think this is an important element that needs to be taken into consideration. Just 2 points on basically WHO's role in relation to prioritization of interventions. Actually, we normally don't do this. Our approach is obviously we issue recommendations and general guidance, and the approach of this organization is essentially to help countries that they are equipped to take decisions on their own based on the best available information. And in the booklet that was circulated, you have examples like the PROVAC exercise, which is particularly focusing on health economic considerations. and then obviously the efforts that are underway to support national immunization technical advisory groups, really to take rational decisions on vaccine introduction. But there are sometimes needs for prioritization, and I'm sure Alex will point to this in relation to GAVI's vaccine investment strategy, where, again, in the world of finite resources, you need to draw a line somewhere. And so some type of decisions needs to be taken. And actually in that context, we did, for the vaccine investment strategy of GAVI in 2008, we did disease prioritization, which is mentioned, which actually was looking at this effort of multiple attribute consideration in a slightly different manner. And we did it, again, as I said, just for the diseases. In principle, it is very attractive because once you are comparing to some extent apples and oranges, you need to see how you bring them together. And if you look at the disease, vaccines against a disease that is endemic versus a disease which particularly has, let's say, epidemic potential, you're looking at two things that are actually quite different. And so the idea of looking at various attributes in a weighted manner is certainly an attractive one. The question is it feasible? Can it be done? Can it be done in such a way that is actually really helpful in decision-making on introduction of vaccines or also in R&D financing? So in relation to the usefulness of the tool, what I personally think is that I think it has great potential, but I think there's a couple of things where really consideration needs to be given. And one element that was pointed out by Carol Hellman earlier was, this concern about discretionary use of this tool, which means basically somebody comes and takes whatever is data there and selects the attributes as wanted, and then you get the results you probably want to have, because it is very clear that such a tool allows for utility bias. You can tweak the system in a way that you get the outcome that you want. So I think this is something that needs to be looked at extremely carefully. There's the data element. I come to this in a minute. But there's another element I wanted to put out here, and this is basically the weighting and the ranking of the attributes. Because obviously this is also a choice, but the question is, how do you make this choice? And this was a consideration we had, for instance, in our exercise on the disease prioritization, where there was a consensus building process in order to come to a consensus about the ranking of the attributes. Obviously here you have something that is highly flexible, so you want to do it in a specific context, but I think if a country or any institution wants to use this institution needs to think about a process, rational, transparent, about ranking the attributes. I think this is absolutely critical. And actually, if you think about these 29 attributes, which in the end are not 29, but you basically can only select a menu of 5 or 6 from them, because the rest then are of no value, it makes it even more clear that you need to have a process on which you agree in the context you are in, about which attributes you use. And this is not an easy thing. And that's something which I think currently is not taken into consideration. I personally think this is a quite important thing. Then in relation to the usefulness, I mean, a score is a score. So what do people do with a score? I think, I mean, obviously that's the nature of this analysis, but we know from work in countries that, I mean, the usual measure of cost to utility is for some people already very abstract. And so a score might not be easy to communicate, and it's probably not the primary thing you would communicate. Again, it is a decision support thing, and then you need to put it into some other type of context. But I think a score as such will probably not convince. Usability, I mean, obviously I cannot comment on the software. I just think what you need to do is very, very clearly to look at, you really need to have in-depth discussion with users, potential users, and you need to understand whether the things you put in the model are really there. I was looking through this, but in my superficial reading, and I'm really not an expert, I had questions, what is it actually what you measure at vaccine cost? Does it include the cost of delivery? You always come back with the cost of complications, which means vaccine severe events. So is this really so critical? Where do you have the systems cost and so forth? So I think these are elements that need to be looked at in the specific context of talking really to potential users. The biggest concern clearly, as voiced by many, and for me this is so to say the trick where we need to look at whether the whole thing is feasible on the basis of such a broad set of attributes, is the data. That's very clear. I mean, we don't have many data, that's absolutely clear. Population data are pretty straightforward, but once you come to disease data, it gets already very tricky. And very often you have burden data in relation to the syndrome, but not in relation to the etiology. You don't have the age-specific incidence clearly lined out. If you're looking at vaccines that are for older populations, you won't have anything. So this is quite tricky. And again, I'm not saying that you cannot do it, but you need to have a very solid process of gathering the data. You need to have a validation process. And you need to be very clear about where, so to say, the evidences are no longer available, and then you need an expert opinion process and so forth. I think the development of a database together with the tool is a very important element of the overall value. And this is currently not in. I mean, you have been focusing on the tool. For me, now comes the data, and the data will be extremely important. And obviously, you rely on partners, but having a process and having a validation step is extremely important. The same is actually, by the way, for the pipeline, because we have the Jordan report and so forth, but we have a lot of pipeline information today that is basically private and confidential, and it would be terrific to have a resource that also the public can use. Enhancements of the tool. The thing which for me stands out most importantly is basically how to deal with parameter uncertainty. You have addressed it, you have discussed it a little bit, but I honestly think that you have to take this very seriously. You need to take, at least for key parameters, you need to think about how do you bring in and how do you depict the uncertainty around those. And my personal fear is, again, being a non-expert, is are you kind of accumulating these uncertainties? So this is something where I'm not entirely clear about, but I think this is something that is absolutely critical you need to do, and I think which the tool needs to provide. You need to do outreach, I think, in relation to really also field testing or pilot testing this tool, and where you will probably get a lot of insights in terms of what is missing, what is not missing, or what you may actually not need. These are, for me, really the main points I would like to convey. So really my take-home message is that I think it's really a very ambitious approach. I think it hinges a lot on the availability of the data and having this data validated in a way that it is acceptable. I personally think one needs to reflect on ways in taking out this notion of discretionary use. Again, in an institutional context, you can work, again, on a process on defining attributes, which I think would already be quite helpful. And then definitively you need to manage the uncertainty and at least or have a proper description of the uncertainty as it comes with this scoring process. That's pretty much it. For the time being, I think it's a research tool. It's something that is thought-provoking. To make it a decision assistance tool is a lot of work, in particular in relation to the data, I presume. Thank you.
Thank you, Joachim. We caught the phrase pilot testing or field testing, and if we have time for questions, I'd like we'll come back to you afterwards to have you envision for us what that might look like. Okay, great, thank you. So now we'll go to the phone. Ademola, are you there? No. Okay, we'll come back at the end. We'll wrap back around. Excellent. So Alex Palacios, Special Representative, GAVI Alliance. Thank you.
Thank you very much. I think one of the challenges of being the 12th or 13th speaker of the day is that some of the points have already been made, so I'll do my best to avoid repeating too much. Let me just say a few words for those who may not know about the GAVI Alliance. It's a public-private global health partnership, Some of our key partners are in the room here today, UNICEF, or online, UNICEF and WHO. The US and Canada are very strong supporters, and our closest partners, of course, at the end of the day, are ministries of health and some civil society partners in developing countries. We have provided support over the last 12 years to about 75, 76 countries. Commitments number in the range of $5+ billion. The bulk of that has been for support of introduction of new and underused vaccines. The vaccine portfolio includes the pentavalent vaccine, pneumococcal vaccine, rotavirus, HPV, meningococcal A, yellow fever, measles, rubella, and we're looking for future support at supporting Japanese encephalitis and typhoid conjugate vaccines. So it's a growing portfolio, started smaller, but it's gotten bigger over time. We're dealing with a significant number of countries, very resource-challenged countries. That issue has come up here already. This tool is going to be very useful, I think, but we need to take into account, as others have, some of the data challenges that exist in those very, very poor resource settings, cold chain challenges, and how to capture the demand and the issues that will arise in country. Again, we see it, certainly this tool is having value, and it helps us to compare and assess a portfolio of vaccine options and allows assessing the trade-offs between them. GAVI itself has recognized for a number of years the need to look in parallel at various vaccines for potential future funding, rather than addressing that through individual investment cases. We had our first such vaccine investment strategy as looking at a portfolio in 2008, and we've just started an update of the vaccine investment strategy to inform potential investments in new vaccines for the period 2014 to 2019. So this is actually a timely discussion for us, and we'll be following it with interest. In terms of the choices of attributes, we find them, of course, very comprehensive, and they overlap to a large extent with those that the GAVI Alliance is using when making investment decisions in the context of a vaccine investment strategy. We're pleased to see that the tool also enables the user to value and weight individual criteria differently in the prioritization process and to add new criteria. And of course, we've learned through our own work in our own vaccine investment strategy process that stakeholders will differ in how they weight and the weight that they attribute to particular criteria. I think my colleague from WHO has already mentioned the distinction between endemic and epidemic diseases, and that's something I think that needs to be considered with regard to this tool. Countries are going to look at those two very, very different, and we just strongly encourage you to reach out. We note that you were looking at just 2 countries in this case, no least developed countries. We think that you really strongly recommend the notion of a field testing, engaging and consulting with countries, a good number of them, particularly in the least developed group. Data challenge, that's come up. I'm not going to repeat it, but very clearly the challenge is to populate this tool with credible numbers and assumptions, and particularly in the most countries with the greatest challenge on systems, that's going to be very, very difficult, very challenging. In terms of cost, another complexity that arises is that the cost of vaccines will be different, of course, depending on the market, country's income level, and other factors, such as whether or not there is a particular procurement mechanism in place. GAVI and a number of donors, including Canada, have a number of years ago created the Advanced Market Commitment Pilot for pneumococcal vaccines that has set a specific price for a vaccine, and of course that will have potentially an impact on how you address the issue of cost. Finally, I just want to note, in terms of one particular difficulty with assessing the pipeline vaccines is the uncertainty about key product characteristics such as vaccine efficacy, for example. We experienced this challenge in the GAVI vaccine investment strategy, where different assumptions about the potential efficacy can significantly alter the overall health impact or cost effectiveness estimates. From a user perspective, the value of the tool could increase significantly if key assumptions were provided by the disease vaccine experts and all already included in the model. Happy to answer any questions beyond these points. Thank you.
Great, thank you. We're moving very quickly. Okay, Genevieve from GSK via phone.
Hi there. Can you hear me?
Yes, we can.
Okay, great. Well, firstly, thank you, and I know it's very difficult to hear on the phone, so I'm going to try and keep it as succinct as possible. A lot of the issues have already been raised, but I think our main objective here is also to thank the SMART vaccine team for their development and their work so far. We do applaud and appreciate the work done by the team, and it's been a huge feat. I can sincerely imagine that. But as we've already said, the parameterization of the model is key, as the evidence entered in would drive the confidence in the model. We need to appropriately model the burden and the outcomes that would sometimes require more sophisticated modeling activities. Therefore, for more complex scientific understanding of certain diseases with complicated population dynamics and transmission dynamics, including serotype interactions, as well as the prophylactic impact of the vaccination, the model could be an oversimplification of what is required. And the model could end up oversimplifying and not be as useful as one would like. For some of the more better characterized infectious diseases, with adequately supported evidence, simple dynamics, the model would be sufficient. And no matter how we'd all like to say that one size fits all, we all understand that this is not the case in this situation. And as vaccines move to more complex innovations, this model might not be sufficient to support all those changes in the current innovation. What is also important is that the model does generally tend to focus on future developments and future horizons. Well, we do see that the current use of current uptake and current interventions is where the model will be used on a more regular basis. So there's a notion of allowing the user to change the coverages, to amend the vaccine efficacies and the population dynamics to be a lot more useful, and therefore allowing the user, at the minute you're only able to enter one coverage, which is the status quo, but hopefully the model can be adapted to allow multiple coverages and multiple scenario analyses. And I think that will help at state level, at country level, and in other situations about how we can improve uptake. It's not just to improve vaccine delivery, but also vaccine coverage and vaccination programs. The model as well, instead of just comparing to no vaccine, we do know that in the majority of the developed countries, we do have vaccination programs in place. So having a no vaccine with a current vaccine and maybe the opportunity for a new vaccine parameter to be entered should be of standard practice and encouraged. And with those current vaccine efficacies and data and outcomes, those could be pre-populated to avoid any misconception or errors in the entry. We also identified that the levels and ranking would need to be reviewed as the notion of cost saving and cost effectiveness would need to be more granular than the current model actually allows. Those cost saving and cost effectiveness to a certain level are regarded as a level 1, whereas we know that a lot of the stakeholders would appreciate those two differences as a level 1 and a level 2 rather, up to a certain level of cost saving. and would have a difference in the priorities in that case. And the move to multi-criteria decision modeling is inevitable. And with this in mind, GSK has started research in this area in order to support developing economies where the notions of maybe qualities and utilities are a lot less of concern, but where more budgets and access and priorities are the major hurdles. And Patricia from Iowa Department of Health raised this in terms that budget optimization is actually something to be considered here, because we have programs in place like insecticide spraying, nets, as well as a vaccination program, and allowing countries, specifically developing countries, to integrate these practices and programs into a platform that allows them to manage and contribute to those different programs as an entirety would be more useful. The next issue that, or the item that we thought would be of major use would be to be able to distinguish between the DALIs and the QALIs that are currently in the model. They're associated to a one level without the distinction between one or the other. And they aren't equivalent, and the time horizons of the model would implicate the benefits that would be achieved if a DALI or a QALI were to be used. Therefore, we should look at making those distinguishable, but also including the time horizons which are appropriate for the different diseases, and allowing the user to choose the time horizon as appropriate, but also the modeling type that would be chosen. We know at the minute, as Charles described the model, it's the Honda version and not the Ferrari version. But maybe the vision of the Ferrari would be the ability to choose between a compartmental decision tree or Markov model, and allow the time horizons to be modified according to the disease, as well as the requirement for, let's say, a booster, or their interaction between the serotypes. When coming to the data and the library, how the referencing was introduced and the rationale for the referencing might be of use in terms of validation and acceptance of the model, as well as the inputs. That could be of something that might be useful to integrate into the model. And the notion at country level rather than state, region, and sub-region level, we do identify that within developing countries, regional level information and distinguishing factors within the model have been of most concern to our stakeholders. And integration of this might be better reflective and supportive of those programs. And constant reassessment of the model on a regular basis via a dynamic process is necessary. And we need to encourage regular updates and a review within a minimum period of, let's say, 5 years after program initiation, but also at regular intervals to understand the impact of the program and understand the impact, as well as modify the program as necessary based on those. Another suggestion would be for the model, for a specific country to upload the model for public review, almost like a Wikipedia-type format or platform. And modifications can be made by stakeholders in a transparent fashion until a version is reached that is reflective of the best supportive evidence. This will result in a model that can be continually updated and modified in a fluid fashion. Methods of vaccine delivery, and as I said, we're getting more complex in our innovations, and the reliance on the cold chain and oral formulations in developing countries would be a key attribute. And therefore, the requirement to update the attributes to reflect the different formulations and delivery methods would be most useful. And also the method on one of the cost developments of introducing a model does not match the defined cost. So we have these one-off costs that would need to be entered into the model by country level. While this is useful at the registration level where the regulatory costs need to be covered, research and development costs are not attributed in that form, and neither are costs. Therefore, that also needs to be reviewed in terms of how that one-off cost is attributed at the country level. R&D programs generally stretch across several countries at any point in time. The requirement to test the model, maybe with the published models and model inputs to ensure consistency of results, could be a method of quality control and validation. So taking a published paper and just inputting the results and testing the model in terms of, do the outcomes reflect what's in the model? And specifically a model that does have stochasticity around it and allows for sensitivity analyses. There are several other points, but I think it's better to, I've covered the major ones. Thank you.